Good afternoon. Today, it is my pleasure and honor to start the second day of one of the most important courses in nephrology and radiology, Nephro-urology of urinary tract. Today, we have two eminent speakers from the field of radiology, Professor Hossam M Gad, the current chief of radiology department at Urology and Nephrology Center, and one of the most enthusiastic and active professors in the field of nuclear medicine, because he is dedicated for more than 30 years acting with all the fields of nephro and urinary tract radiology, but he is focusing on the renogram and the nuclear medicine in the field of urinary tract. We are honored today and have the privilege to have Professor Hossam with us to concentrate and focus on radionuclide studies in the field of nephrology renogram. And today I'm very happy to introduce Professor Hossam. Professor Hossam.
Good afternoon. Today we try to take an idea about radionuclides in nephro-urology. Indication of scintigraphy in radionuclides in nephro-urology are evaluation of renal perfusion, evaluation of the renal function, diagnosis of obstruction by LASIK renal scan, and diagnosis of renovascular hypertension due to any vascular cause as atherosclerosis, renal stenosis, diagnosis of infection by renal morphology scan, detection of congenital anomalies, detection of renal parenchymal lesions by renal morphology scan, and take a decision to nephrectomize or remaining any kidney pre-surgical. Lastly, follow-up of renal transplant and diagnosis of all parenchymal medical complication and surgical complication. Radionuclides in nephrology are either dynamic for functional evaluation or static for anatomical assessment as pionuclides. Renal pharmaceuticals are tracers for dynamic studies as technetium-99 DTPA, which is cleared by glomerular filtration, and technetium-99 MAC3, which cleared by tubular secretion. Tracers for static studies, the most famous is technetium-99 DEMSA, which is cleared by tubular secretion and retained in the renal cortex and minimally excreted in urine. Dynamic studies are made by either technetium-99 DTPA or technetium-99 MAC3. Technetium-99 DTPA by ethylene triamino-pentaacetic acid, the dose is 3 to 5 millicoulombs. Excretion by glomerular filtration. Indications of these studies are for assessment of renal perfusion, renal function by calculation of GFR, glomerular filtration rate, and detection of renal urethral obstruction. It is less reliable for renal cortical details or renal size. However, technetium MAC3, mercaptoacetyl triglycine, the dose is 10 millicoulombs. Indication of technetium MAC3 is for detection of renal perfusion, renal function by calculation of effective renal plasma flow, from which GFR can be calculated by a certain equation. As regards patient preparation, the patient must be well hydrated 30 to 60 minutes pre-injection, void before injection, and void at the end of the start. The patient lies supine with the detector beneath both kidneys. We take region of interest for both kidneys and subground for subtraction. Renogram phases are 3 phases: vascular or perfusion phase. In the first minute, the kidney to aorta ratio must be more equal to 3:1 to 1 or more. Uptake phase in the following 5 minutes, represented by ascending limb in the curve, and finally excretory phase. We must put in mind that there is not pure uptake phase and pure excretory phase, but excretion occur in the uptake phase and uptake occur in the excretory phase. But there is in the uptake phase there is uptake predominance, and in the excretion phase there is excretion predominance. This is an example for the renogram curve. This is the ascending limb with the summit at 2.5 to 5 minutes, and then followed by the excretion phase. This is a multiple map for a normal case by DTBA, where the aorta appears in the middle with both kidneys on both sides. We noticed that the uptake and perfusion accumulation of the tracer is more than the aorta by 3 times. This is the remaining part of the scan, represents the uptake phase. This is the uptake phase. Both kidneys show good tracer uptake, and then begin the excretory phase after that, with complete washout of the tracer by the end of the study and the appearing of the bladder. One of the benefits of radio-nuclides in nephrology is can differentiate between chronic and acute renal failure. In acute renal failure, the perfusion will be mildly reduced or preserved. There is mild reduction in tracer uptake, some delay in excretion due to parenchymal tension. However, in chronic renal failure, there is marked reduction in perfusion phase, marked reduction in tracer uptake, and the excretory phase was not affected. In both studies, there is marked increase in background activity. Example for acute renal failure, where the kidney appears in the perfusion phase with good or mild reduction in perfusion. Then in uptake phase, good or mild reduction in tracer uptake, and no obstruction. There is the bladder in the end here with some parenchymal retention of the trace. However, in chronic renal failure, as we see here in the perfusion phase, there is marked reduction in the perfusion of both kidneys, followed by marked reduction in the uptake of both kidneys, and also with reasonable excretion rate, and the bladder appeared at the end of the study. So the main differentiating point between acute and chronic renal failure is the perfusion phase. Perfusion phase in the acute renal failure is mildly reduced or preserved. However, it is markedly reduced in chronic renal failure. Now, another point, evaluation of hydronephrosis or detection of obstruction. Obstruction to urine outflow leads to obstructive uropathy, which is lead to obstructive nephropathy if neglected. Tracer pooling in dilated renal pelvis. When we inject Lasix, it induces increased urine flow. If obstructed, will not wash out. If dilated, non-obstructed, it will wash out. We must put in mind that T-half must be calculated in these studies, as T-half can assist diagnosis of it. What is T-half? T-half is the time needed for the kidney to wash out half of the quantity of count taken by it, and normally it is 10 minutes or less. This is normal T-half. If it is more than 20 minutes, it is obstructed. If it is between 10 to 20 minutes, this is we called unequivocal response to diuresis, which means that we cannot decide if it is obstructed or not. In this case, we decide to make minus 15-minute diuretic start. What is the minus 15 minutes? Minus 15 minutes is injecting Lasix 15 minutes before the diuretic study, and it is the sure diagnostic method for obstruction. The question here, why we don't use minus 15 minute study from the start? In all these studies, we want to detect if it is obstructed or not, in addition to calculation of GFR to assess the renal function. If we inject the Lasix 15 minutes before the study, this will affect the blood osmolarity. Affection of this blood osmolarity will give false result for GFR, because we take region of interest for calculation of GFR between 2 and 3 minutes. In the case of minus 15 minutes, this will widen the diuresis will in the blood and affect the osmolarity. So we use plus F plus 10 minutes, in which we inject Lasix 10 minutes after beginning of the study. And we can calculate GFR in the first 2 to 3 minutes. This is an example for a case where the right kidney, as we see here, showed reduced perfusion and tracer uptake and raised excretion with tracer retention along its pelvis. So we inject Lasix, and this is the effect of the Lasix. Here is the retention. After injecting Lasix, there is complete washout. So it is dilated non-obstructed case. However, in this case, there is reduction in the perfusion and tracer uptake of the right kidney, and delayed excretion with tracer holding along its pelvic calyceal system. When we inject Lasix in this case, there is no response to Lasix along the case until the end of the study. So this is obstructed right. Another case, the right kidney here also showed mild, relative mild reduction with tracer retention along its pelvic ureteric junction. We inject Lasix, showed this is the total or global region of interest for the kidney, and the Lasix here, no response. This is flat curve, not descending to toward the baseline. Here, for calculation of GFR, we exclude the renal pelvis at here in the region of interest, and this is taken at 2 to 3 minutes. But for assessment of obstruction, we take global for the whole kidney region of interest to evaluate presence or absence of obstruction. As we mentioned before, this is the T-half and the definition of it. The 10 minutes, less than 10 minutes, normal or non-obstructed. More than 20 minutes obstructed. 10 to 20 minutes intermediate with equivocal response, for which minus 15 minutes is indicated. For interpretation for renal scan to diagnose obstruction, we depend mainly on the visual interpretation and assessed by the renal curve and calculation of T-half only to ensure presence or absence of obstruction. So no dependence on the curve only or T-half only, but this is co-sides for visual interpretation. F-15 diuretic renogram, where the furosemide is injected 15 minutes before the radiopharmaceutical, make the kidney in maximum diuresis. It is indicated in equivocal response cases. The third indication for radio-nuclides in nephrology is evaluation of renovascular hypertension, Captopril renal scan, ACEI inhibitor renography. Renovascular hypertension caused by renal hypoperfusion due to atherosclerosis, fibromuscular dysplasia, renal artery stenosis. The gold standard for diagnosis of renal artery stenosis is angiography, ACEI inhibitor renography, Doppler sonography, and other tests are CT angiography and MR angiography. Patient must be prepared before ACEI inhibitor renography by no receptor blocks 3 to 7 days before the scan, off all diuretics 5 to 7 days before the scan, no solid food 4 hours before the scan, and patient must be well hydrated. The dose is 25 to 50 milligrams per orally 1 hour before the scan. This is an example. And when there is the renovascular hypertension is suspected, we do 2 scans. One basal scan without Captopril, and another Captopril renography 5 days after the basal scan. This is an example for basal scan where there is some retention of the tracer here in the right kidney, but it is washed. So the hypertension mean is suspected to be renovascular as it was not accepted to medical treatment. For this reason, we did Captopril renography 5 days after, and as we see here, there is mild reduction in perfusion of the right kidney, and mild reduction is tracer uptake, and delayed excretion with severe parenchymal retention of the tracer, which appeared here on the curve. This point of severe parenchymal retention of the tracer is the most characteristic scintigraphic point for diagnosing renovascular hypertension. Another example, this is the basal one, mild reduction in perfusion tracer uptake of the right kidney. With this curve, where there is flat peak with slight descent in the excretion curve. So Captopril renography is done 5 days after, which reveals marked reduction in perfusion and tracer uptake of the right kidney, together with severe parenchymal retention of the tracer as appears in this curve. So this severe parenchymal retention also is a diagnostic point for renovascular hypertension. Grading of renogram curve in cases of ACEI inhibitor. This is the normal curve, and this is grade 1 curve as the last case, where there is flat peak with some descent, and grade 2A, some descent with flat peak, and grade 2B, where there is marked parenchymal retention of the tracer with flat rising curve. And lastly, grade 3, when the renal systems affect the renal function, so it appeared with less marked reduction in renal function and affection of the renal function. Another example, there is good perfusion and tracer uptake of the left kidney. However, the right kidney was not perfused. It was a case of renal artery occlusion. Some examples for congenital anomalies of the kidney diagnosed by renal scintigraphy. Fused cause of crossed fused ectopic right kidney. We see here, this is the left kidney, and this is down to it. It is the crossed ectopic right kidney. We take region of interest here for the left kidney. This is dense one, and the another one, this another region of interest for the crossed ectopic right kidney. And these are the curves of the left and curves of the crossed ectopic right. A case of left renal cyst, as we see here. There is photopenic area occupying upper half of the left kidney, is the renal cyst. A case for example for duplicated right kidney, as we see here, there is dense part upward. This is the upper moiety, and less dense with photopenic portion in the lower half. This is the lower moiety. We take region of interest for both moieties. This is the upper and this is the lower. And this is the percentage between 18% for the lower moiety and the remaining of 100 for the upper moiety. And we can take region of interest for the whole kidney to calculate all the GFR of the kidney, duplex kidney. And by multiplying the GFR, my total GFR by the percentage of each moiety, we can calculate the GFR of each moiety. An example for ectopic right kidney, as you see here, this is the left one in its normal position, and this is the right ectopic pelvic kidney. Example for horseshoe kidney, this is the right compartment, left compartment with the fibrous band in between the lower ends, and we can also calculate GFR for and spread function for each compartment. Another example for supernumerary kidney. Actually, in this case, there are two congenital anomalies. The first is cross the ectopic. Cross the ectopic left kidney here downward, and this is the right kidney in its normal position. This is cross the ectopic left kidney, and another congenital anomaly with this point, hot point, it is a supernumerary kidney, 3 kidneys in this case. Another case, congenital anomaly, this is polycystic kidney, where both kidneys appear here with enlarged inside with multiple photopenic areas, as you see, with increased background activity. As we know, all polycystic disease, polycystic kidney disease in the age of 50 must end by chronic renal failure. The following indication of radio-nuclides is how to follow up the renal transplant and selection of donors before transplant. So, indication of assessment of the donor, the outcome 1, and the other is assessment of the recipient before transplantation. Then detection of complications of the renal graft after transplantation, either parenchymal medical complications as ATN in the first month, and rejection, cyclosporine or FK or any immunosuppressive toxicity, other surgical complications as obstruction, vascular complications, leakage. Any of these can be done by radio-nuclides. Firstly, this is a normal donor with we make radio scintigraphic study for all donors before transplantation to choose the kidney with less function to be transplanted. And as we see here, this is the perfusion phase. This is the left kidney and this right kidney. If you notice and compare left to the right, both are normal, yes, but the right kidney showed slight mild relative reduction in comparison to the left side. And when we take region of interest for both kidneys to calculate split renal function, this is the result. The left kidney is 50.5%, and the right kidney is 49.5%. So we will choose this right kidney for transplant. This is a renal transplant recently renal graft recently transplanted. As we see here, this is a very good perfusion. Very good perfusion, followed by good tracer uptake and good excretion. This scintigraphic study is done for all renal transplants just after going out from the ICU and become stable in all renal functions. So we make scintigraphic basal scintigraphic study, which is used after that for comparison in cases of complication after that. This good perfusion, as we said, and good tracer uptake and good drainage. And this is the curve. Firstly, we will discuss the renal transplant complication. This is a case of acute rejection in which there is marked reduction in renal perfusion. What is the graph here? The graph here appears at the end of the first minute of vascular phase and very faint, okay? Followed by reduction in tracer uptake and delayed excretion, but it is not obstructed. So this three scintigraphic criteria are the diagnostic for acute rejection. The only complication which can be compared with acute rejection is immunosuppressive toxicity, as FK, cyclosporin, or what. So when we see these scintigraphic criteria, we must ask about the level of immunosuppressive in blood. If it is high, so this picture is diagnostic for immunosuppressive toxicity. If it is normal, so it is surely acute rejection. Another example is acute tubular necrosis ATN. Normally, it occurs 1 month after transplantation, within the first month after transplantation. As we see here, the perfusion, not that of the acute rejection, the perfusion here is mildly reduced or preserved, and mild reduction in tracer uptake, and then marked delay in excretion due to severe parenchymal retention of tracer with this obstructed-like curve. It is not obstruction, but there is severe parenchymal retention of tracer lead to this rising curve. This three criteria are diagnostic also for acute tubular necrosis. Mild reduction, reduced or preserved perfusion, mild reduction in tracer uptake, and delayed excretion due to severe parenchymal tension of the tracer. Another example for AKM, as we see here, also the perfusion is mild reduced or preserved. As we see here, this is aorta and aorta bifurcation for both iliac arteries, and this is the graph appeared here. If we follow the graph take the radioactive tracer, and it is more or less perfused together with reduction in tracer uptake and marked delay in excretion due to severe parenchymal of the tracer with this obstructed like curve. So this triad in the first month, within the first month after transplantation, is diagnostic for acute tubular necrosis. Another case of acute tubular necrosis, preserved perfusion or mild reduced tracer uptake, and is reduced almost, but mild reduction, and delayed excretion, and this is the curve of the case. This is a case of FK toxicity with some reduction in perfusion, some reduction in tracer uptake, delayed excretion, but it is not obstructed, and this is the curve of FK toxicity. And as we mentioned before, we must ask for, if we say reduction in perfusion, reduction in tracer uptake, some delay in excretion, but it is not obstructed, we must ask about FK or cyclosporin toxicity level. If it is high, so this trial is diagnostic for cyclosporin toxicity, and if it is normal, this trial can be diagnosed acute rejection. FK toxicity. In this case, we notice that there is accumulation of the radioactive tracer as medial to the lower third of the retina. It is a case of urinoma. Now we can discuss the static studies by technetium-99 DEMSA. We detect cold defect in this study, maybe acute or chronic pyelonephritis, hydronephrosis, cyst, tumor, trauma, contusion, laceration, rupture, hematoma, infarction, and differential diagnosis of basic lesion from pseudotumor. The procedure here is done by technetium-99 DEMSA. The dose is 3 to 5 millicurie. We take images 2 hours post-injection. Images will be post-anterior image and both obliques, right and left oblique. Technetium-99 DEMSA, dicaptosuccinic acid. Indications for use: is it a tracer of choice for renal parenchyma evaluation? Not suitable for perfusion or obstruction. Limited function assessment, but can assess and calculate relative outlet uptake. We can differentiate between acute, by this technetium-99 DEMSA, acute pyelonephritis and chronic pyelonephritis. In acute pyelonephritis, there is enlarged kidney with smooth outline, together with cold photopenic areas. However, in chronic pyelonephritis, the kidney is smaller in size, with reduced uptake and irregular outline, with cortical photopenic areas which is scarring by ultrasound or any other radiological method. According to the DEMSA in chronic painful, we can make a grading for this DEMSA. Grade 0 normal, normal DEMSA scan. In grade 1, there is one cortical photopenic area or reduced uptake, less than 45%. Grade 2, combination between one cortical photopenic area and reduced uptake. And grade 3, when there is more than one cortical photopenic area. Example for normal DEMSA scan, as we see here, both kidneys show good tracer uptake with homogeneous distribution of the radioactive tracer without detectable cortical photopenic areas. This is the posterior anterior. This is the left oblique, and this is the right oblique. This is the relative split uptake with the left kidney 40% and the right kidney 53%. In this case, if we see the left kidney, it should good tracer uptake in comparison to the right, but in the upper pool here, there is cortical photopenic area, and this can be confirmed by presence of this cortical photopenic area in the oblique view of the left kidney. So there is solitary cortical photopenic area in the left kidney without reduction in the tracer uptake. So it is diagnosed at grade 1 by immunofluorescence check. However, the right kidney handles tracer normal. If we see here the split uptake to confirm our diagnosis, we will find split uptake of the left kidney 49%, and in the right kidney is approximately 51%. Another case where there is reduction in tracer uptake of the left kidney here, together with photopenic area here, cold area in the upper pool, and confirmed that it is present in the oblique view. So there is reduction in tracer uptake together with single photopenic area. This combination means that it is grade 2 by immunofluorescence changes. However, the right kidney handles tracer normally. We can confirm this by the relative split uptake. For the left kidney, it is 41, and for the right kidney, it is 59%. Another case of DEMSA scan where both kidneys showed multiple cortical photopenic areas, so it is grade 3 by immunofluorescence changes. This is a case of acute pyelonephritis where the kidney is enlarged with homogeneous reduction in tracer uptake and multiple photopenic areas in the kidney. So it is acute, not chronic pyelonephritis. An example for the case of grade 1 pyelonephritic change by detection of this cortical photopenic area in the upper zone. And this is the same case after treatment with this recovery. Now it is completely normal. By technetium-99 static DEMSA scan, we can also detect congenital anomalies as agenesis, ectopic kidney, fusion, horseshoe or cross-diffused ectopic, polycystic kidney, multicystic dysplastic kidney, and pseudomasses, focal lobulation, hypertrophic column of Bertini. A case of horseshoe kidney. Both compartments appear here. Left compartment, right compartment with the fibrous band in between. Left renal agenesis, no uptake by the left kidney. Good uptake and normal DENSA scan of the right kidney. Ectopic right kidney. Cross-diffused ectopic left kidney. Polycystic kidney. Enlarged both kidneys with multiple photopenic areas. Thank you very much. Any questions for this lecture?
So at the end of this presentation, I would like to thank and appreciate the efforts done by Professor Hossam. As I mentioned in the beginning, he is very enthusiastic for renogram. Although nowadays we are restricting the use of renogram in nephrology to the few sectors like the donor, because here in our center we want to know the share of each kidney by GFR, so isolate the split function of the kidneys, and the share of each kidney is important in decision making for selecting whether to take the right kidney or the left kidney according to the renogram. So this is our practice here. And one of the important point is, if we think in the gold standard evaluation of GFR, glomerular filtration rate, all over the world, the isotope clearance is the gold standard. But when they use the gold standard, they didn't depend upon the area of interest by renogram. They depend on the evaluating the isotope in the blood and urine. So this is one of important issues and important indications. Now, if you have any question to Professor Hossam, I'll be happy to receive your question. Anyone has any question, just raise your hand or write on the chat your question. Regarding the difference in renogram on the drug nephrotoxicity and rejection, you mentioned FK, tacrolimus toxicity.
Yes, yes.
Is it applied? Is it practical?
Yes, it's applied and practical.
So they want to just to know
when we see the same scintigraphic criteria for rejection and immunosuppressive toxicity, they are the same scintigraphic criteria, which are reduction in perfusion, reduction in tracer uptake, and some re-excretion in excretion, but without obstruction. When we see all these scintigraphic criteria, we belong to see the level of immunosuppression in blood. If it is very high level, so it is cyclosporine toxicity. If the immunosuppression level in the blood is normal, so these scintigraphic criteria are due to acute rejection.
So again, regarding this point, I would like just to concentrate. We need renogram to know is it obstructed graft or not.
Yeah.
But regarding nephrotoxicity or diagnosis of rejection by renogram, by Doppler ultrasound, by MRI, as nephrologists, this is a nephrology perspective. We cannot depend solely on radiology. We depend upon biopsy up to this moment.
Yes.
Although,
standard, yes.
although we have many publications from here, from the Urology and Nephrology Center, either from Doppler studies, MRI studies, non-invasive methods, and renographic criteria. But as from the nephrology, transplant nephrology perspectives, we don't trust radiology in diagnosing rejection. But it is, as I mentioned, it is one of the tools. So we have creatinine, we have laboratory drug levels, we have ultrasound criteria, Doppler criteria, and today we have renographic criteria. But from practical point of view, we don't consider so much renogram as a diagnostic for rejection.
I think that radiology is a guide for you.
Yes. So it helps. It helps us.
Yes, yes. Because you can exclude obstruction,
yes,
which is the main point, and confirm that the problem for you is a parenchymal medical problem. So we suggest, just suggestion, it may be acute rejection for confirmation by biopsy. And
sometimes we ask Professor Hossam for a renogram for a case when we see by ultrasound hydronephrosis. Sometimes it is not obstructive, it is reflux. So does renogram help us in discriminating obstruction from reflux?
Yes, yes, how? Yes, yes. When you mention that this patient has suspicion of reflux, from the beginning we make urethral caster for this patient, and then make the renogram in presence of this urethral caster. In presence of reflux, the delay in excretion will be washed through the urethral caster, and it is not obstructed. If it is not responding to Lasix in presence of the urethral caster, this ensures that it is obstructed.
We have here questions on the chat. One of the questions: what is the difference between DEMSA, MAC3, and other types of radioisotopes like DTPA?
DEMSA is used for static study. Static study means anatomical study. However, DTPA or MAC3 are used for dynamic study. It means functional study. So there is a great difference between. As we mentioned in the lecture, DTPA is watched by glomerular filtration. MAC3 is watched by tubular excretion, and also DEMSA by tubular excretion. By DEMSA, we cannot evaluate the function, but just we note that there is a split function for the uptake, which may be guide me to function. And we do get some papers to for comparison between split uptake and the split function by other dynamic studies, and this papers proved that there is correlation, great correlation between both.
Another point raised here on the chat: can we depend upon DEMSA for diagnosis of chronic kidney disease like diabetes, etc.? From my perspectives as nephrologist, we respect DEMSA to tell us about the scar, if there is any scar or not. So it is valuable in the presence of reflux or pyelonephritis to tell us about the presence of a scar on of this kidney. But as Professor Hossam just mentioned, DTPA and others are dynamic studies. Am I right?
Yes, you are right. In diabetic nephropathy, I think so. The dynamic study is more valuable for than the static study for assessment of renal function and the assessment of renal perfusion and affection of renal perfusion, which may be the most guiding point to affection of renal function.
So we request DEMSA whenever we think of reflux and scarring. Am I right?
Yes.
It's okay. And the rest is dynamic studies according to the availability of tracer. Is there any question? So, so thank you, Professor Hossam, for this excellent presentation.
Thank you.
And your enthusiasm for renogram. It is, as you mentioned, it is a magic bullet added to the strategy of diagnosis. So at certain point of time, like obstructed kidney, we are not sure of obstruction except with renographic study. Thank you, Professor Hossam.
Thank you.
Thank you.
Thank you. Thank you.